Good morning to everyone. Thanks for the presentation. It's a great pleasure for me to be here at ESCMID to speak about the impact of pneumonia panel on the critically ill patients. Pneumonia remains the leading cause of morbidity and mortality in the ICU, and diagnosing pneumonia in the critically ill patients remains a challenge for clinicians because of the principal limitation of the culture traditional methods that may be slow, and thus the clinician have to rely on empirical treatment, but this strategy has several limitations. First of all, to cover the multi-drug resistant bacteria, but also to have an improvement in antimicrobial stewardship. Thus, the pneumonia panel have some advantages in the diagnosis of pneumonia, especially in the critically ill patients, that relies on the time to results that are very short as compared to the traditional methods. Also the ability to detect some pathogens, not only bacteria, but also the viruses, the high sensitivity, and also the ability to detect some resistance genes. However, I think that the fundamental question is how this translates into better therapeutic strategies in critically ill patients. So I think that data that comes from the studies until now have gained some attention on three potential benefits. The first is the reduction in time to effective therapy, so the patient can de-escalate to targeted therapy from broad spectrum antibiotics. The second is to improve the pathogen detection, because we can check also for some bacteria that miss to grow in the culture, maybe because of the use of antibiotic treatment, and also to detect co-infections, bacterial and viral, that is particularly important in the immunocompromised and critically ill patients. And the third one, maybe the most confirmed in all the studies that have been published, is the benefit in antimicrobial stewardship, because with early detection of resistance genes or not detection of resistance genes, we can decrease the unnecessary antibiotic use and thus reduce the resistance pressure. There are also some limits of the pneumonia panel. First of all, we know that there are some bacteria in the panel, not all the bacteria that can be involved in pathogenesis of pneumonia in the critically ill patients. We know that the data on antibiotic susceptibility rely only on some resistance genes, so it's not enough for all the bacteria, for example, non-fermenting gram-negative bacteria like Pseudomonas aeruginosa. The third is the cost, and the last one is the need to correctly interpret the data in the clinical setting. So in the next few minutes, I will show you some results of the studies about the use of pneumopanel in the ICU. The first is a very nice study, a randomized control study that has been performed in the UK, in which 200 of patients were randomized in the two arms. The first is the interventional group with the use of pneumonia panel in the ICU, and the second one was the traditional method group. So the first result is that the diagnosis is more rapid in the intervention group, a median time of 1.7 hours as compared to 66 hours in the standard diagnostic. The second point is the increase in pathogen detection, 71% in the molecular point of care group versus 51% with conventional testing. The third, that is the primary endpoint of the study, the probability of results-directed therapy, was obtained in 80% in the intervention group as compared to 29% in the control group. And the last one, antibiotic de-escalation, was performed in 42% in the intervention group as compared to 8% in the control group. The study was not designed to assess eventual clinical differences in the group, so no clinical outcome has been identified in this study. Another study, very interesting, is this one that I show you that has been performed in the US. It's an observational study, so a pre-interventional, post-interventional cohort in which they evaluated some therapeutic strategies before and after the introduction of pneumonia panel in the ICU in this setting. And they found that their primary endpoint, time to first antibiotic change, was reduced from 50 hours to 21 hours post-intervention, and this was mainly led by the discontinuation of coverage of anti-gram-positive antibiotics and also the escalation of coverage of gram-negative bacteria. The other very interesting aspect of this study is the length of treatment, because days on therapy reduced from 8 days to 6 days, thus improving antimicrobial stewardship items. The third study, I think very, very interesting, is the one that was recently published, 2025, on intensive care medicine, that is the INHALE VUP3. It's a multi-center randomized trial in which patients were randomized to pneumonia panel versus control group. This study has two main primary objectives. The first was the improvement in antibiotic stewardship and was obtained with a gain of 21% in absolute terms. However, and I think also unexpectedly, the second primary endpoint, that was the equivalence of clinical cure, was not demonstrated in this study. And I think that some aspect of this study will be shown in the next lecture, but I think that some insight into this study have to be well considered when we want to improve this syndromic panel in the clinical practice. At Policlinico of Milano, where I work, we introduced the pneumonia panel in the ICU during the COVID-19 pandemic. And thus, after the introduction, we prospectively observed the comparison between diagnosis of ventilatory-associated pneumonia according to what we consider the reference standard, that is the cultural traditional method on bronchoalveolar lavage, as compared to film array pneumonia panel on the same material, so the bronchoalveolar lavage. And as you see in our publication, by a clinical point of view, with the pneumonia panel, we missed two pathogens that had some importance in our casuistic. The first is Aspergillus, that was particularly relevant in this cohort of COVID-19 mechanically ventilated patient. And the second was an outbreak of pneumonia linked to Corynebacterium striatum, that is not a bacteria on target, on panel for the pneumonia panel. But when we evaluated the sensitivity and the specificity of pneumonia panel about the target of the same test, we found a very, very high sensitivity, that is 95%, 100% for some bacterial targets, and a lower specificity as compared to the reference method that was the cultural test. I think that also this point have to be well considered when we use pneumonia panel in the clinical practice, so to gain the real significance of what we found on the molecular target as compared to the cultural one. About our clinical considerations on our cohort of patients and also on our clinical practice, I think that the strand points are principally two. The first is the very short turnaround time, but the second, most importantly, I think, is the ability to anticipate most of the therapeutic choices. Our therapeutic decisions, based on the results of pneumonia panel on bronchoalveolar lavage, were confirmed at the arrival of the test, the cultural test, in more than 80% of the cases. Two limitations I think that we consider when we use the test in the clinical practice. The first is to be aware of what is missing. Beyond the COVID-19, I think that the two most important things are to evaluate also the possibility that our patients have some unusual gram-negative or non-fermenting gram-negative bacteria like Stenotrophomonas maltophilia that, especially in the immune-suppressed patients, can have a role. And the second is that in our clinical practice, we found some discordance in the detection of the antimicrobial resistant genes that were detected in the molecular test, but not in cultural test. And I think that this is also to be considered. Different expert opinion documents try to integrate the molecular test into the flowchart for the diagnosis of pneumonia, and most of them recommend the use of this panel for all the cases of hospital-acquired pneumonia and also ventilatory associated pneumonia, but also in the severe community-acquired pneumonia, especially when the patients have risk factors for MDR bacteria or also a very critical clinical presentation. And we also consider the introduction of this panel in our clinical practice based on two things. The first is our local aggregated antibiotic resistance, that is quite what we see every day in our clinical practice, and the second are the result of the pneumonia panel. So when we suspect in ICU and hospital-acquired or ventilatory-acquired pneumonia, we perform the pneumonia panel, and then according to the results of the test, but also on our local aggregated antibiotic resistant, we do suggestion about the therapy. We think that the application of syndromic panels could be very useful also in the setting of ICU patients immune suppressed, and especially we focused on lung transplantation. We think that in this setting where there are a few experience of the use of the panel, we can be useful almost in two things. The first one is to adjust the prophylaxis of the lung recipients based on rapid results on the bronchoalveolar lavage of the donors. And it is very useful because we received the data about the colonization of the bronchoalveolar lavage of the donor only after some days after transplantation. So the patients, the recipients, underwent a standard prophylaxis and not a targeted prophylaxis. And the second one is another aspect that is linked to the duration of prophylaxis in this setting, because various centers have different schemes and go on for 7 days, also 10 days, also 14 days for prophylaxis in these conditions. And we think that to perform the pneumo panel in the first days after transplantation can add us some data, especially if it's negative, to stop the prophylaxis and so to reduce the pressure of antibiotics. So we created an algorithm that we are using in our clinical practice and on which we are collecting also some data that use and integrate the results of pneumonia panel on the bronchoalveolar lavage of the donor and of the recipients in the first days after transplantation, based on which we used to have some recommendation about the treatment. So I think that pneumonia panels are transforming the ICU pneumonia management nowadays, even if some challenges still remain, and maybe have to be integrated with clinical practice, with traditional culture methods, and also maybe some other rapid tests that could be added to the management of the patients. I think that in the future, we can assist the clinician in result interpretation, maybe with better algorithm, maybe based also on artificial intelligence, maybe combining the pneumonia panel with host response biomarkers can aid us to evaluate the really clinical impact of some pathogens that we found in the test, and also that we need some cost effectiveness analysis to have a broader access of this test in the hospitals. So thank you for your attention, and I look forward for your question and discussion. Thank you.